Good morning, everyone. Today I'll be discussing about the one of the rare late mechanical complication of chemoport is the chemoport catheter fracture. Myself, Dr. Naresh from Surgical Oncology DRNB resident in Rajiv Gandhi Cancer Institute. So actually, my head, Dr. Viswak Chandra sir, he couldn't join us because we had a OT today. So he is operating now. So he couldn't join. So I'll be presenting myself. Uh, And thank you very much, ma'am and sir, for today's CME. As I learned a lot of things about the chemoport insertion, the technical aspects, the demonstration of like insertion and the maintenance and removal. So as far as the this particular complication concerned, the incidence reported in the literature is about 0.5 to 1%, and in our institute it's like 0.2 to 0.3%. And the most common site of the fracture being the proximal part between the resources between the port and the catheter, and usually patient presents with the difficulty in flushing the port, and sometimes most of the times the patients are asymptomatic and sometimes can have the embolization of the catheter into the right atrium or ventricles or maybe deep into the pulmonary vessels and can cause life-threatening complications. So regarding our case, she is a 56-year-old post-menopausal lady, BRCA1 mutant. She was diagnosed with the metachronous bilateral carcinoma breast. She was already treated. She had been already treated outside for the left breast carcinoma in 2009 and for the recurrent lesion in 2015. And she was on follow-up. So this time in February 24, she came with the right breast lump and on evaluation found to be right breast carcinoma. And we did right MRM in February 24, and the stage was PT2 and 2A. So and triple negative breast cancer. So she needed adjuvant chemotherapy. For that, she underwent venous port insertion through the left subclavian vein, and we usually use the barred port with Grosson catheter, 8 French size. So this is the X-ray immediately after the post-op, and according to one study, Hinks et al., uh, they found the most common cause for the subclavian venous port fracture is the pinch-off syndrome, and they graded as grade 0 is normal, grade 1 is abrupt change in the course, and in our case also we found this grade 1 pathology, the abrupt change in the course without luminal narrowing, and the grade 2 is luminal narrowing, and grade 3 is complete catheter fracture. So so she completed the all the cycles adjuvant treatment, and then after 1 year she came back for the follow up. And during follow-ups, we examined the OPD. We found clinically normal, and we flushed the chemoport as well. And the forward and backflow was present, and we sent the patient for routine checkup like chest X-ray. And this after the chest X-ray, we found that the port catheter has fractured at the same site where we found the grade 1 uh, pinch of syndrome. So we explained the patient about this particular complication and took the consent for the removal. And meanwhile, we talked to the IR department, and then we shifted the patient to IR department. And uh, the visible part we removed, and for the floating part in the ventricles, the right femoral vein was punctured and catheterized using Seldinger's technique. And if my pointer is visible, we can see this catheter, and this is the snare loop, and this is the floating catheter. Now I'll start the video. So with the help of this snare loop, we grasp the floating catheter like this, and then we pull through the IVC and then through the right femoral vein, and and we examine the catheter the with the tip, and it was 11 centimeter in length, and there is no thrombus at the tip or tip of the catheter. So, in the literature, we could find some possible causes for the fracture of chemoport. That is like high pressure infusion of for the deobstruction of the catheter and direct catheter injury during insertion by the guide wire or maybe the needle, or pinching of the catheter in the costoclavicular space, that is pinch off syndrome. And some of the case series have mentioned about the manufacturing defect, that is the high concentration of the barium sulfate is also associated with the fracture. And this is the costoclavicular angle. Like some of the case series and case studies have shown that the more medially we will insert the catheter, the more chances of the crushing the catheter and causing a fracture. So in the below picture, we can see the catheter A, B, and C. The catheter C has most stable, and catheter A has the most the higher chances of the port fracture. About the diagnosis, the chest X-ray is needed for the any difficulty in flushing the port, and some of the studies have mentioned that in grade 2 or more, uh, we have to remove the catheter of the grade 2 or more. If the pinch of syndrome is showing, then we have to remove the catheter, or grade 1 we can still observe with the chest x-rays needed for the examination. And regarding the treatment, the endovascular catheter removal should be the treatment of choice, and sometimes may need thoracotomy or a hybrid technique by taking help of the 3D imaging and to locate and then surgery. So the take-home message is the internal jugular vein should be preferred over the subclavian vein, and the lateral part of postoclavicular space should be used as we discussed, and the port catheter should be in the natural axis and position so that it should be like relaxed. And so the junction of the connector and catheter should also be not should not bend, and this should be the board should be properly fixed to prevent the rotation again can cause torsion and can weaken the port catheter. And we should always use fluorescence while inserting, and we should look for the pinch of syndrome if you are feeling if you are like feeling that this patient has the grade 2 or more, then we should immediately remove and reinsert. And the catheter lock mechanism should be designed more soft. And lastly, the once the treatment is over, the port should be removed. Thank you very much.